So next we have risk factors for lower extremity vascular complications in patients on veno-arterial extracorporeal membrane oxygenation by Chesney Seams of University of Minnesota.
Good afternoon. My name is Chesney Seams. I'm a general surgery resident at the University of Minnesota. Thank you to the Society for the opportunity to present our work. The title of our paper is Risk Factors for Lower Extremity Vascular Complications in Patients on Veno-Arterial Extracorporeal Membrane Oxygenation. We have no disclosures. VA ECMO use has significantly increased over the last several decades. Even at the Louvre, you can be placed on ECMO, as pictured here. But despite its widespread use, morbidity and mortality remains high. Prior studies have reported worse outcomes for patients who develop vascular complications while on VA ECMO. However, these studies have been limited by small sample size. We sought to investigate predictive risk factors for vascular complications in patients on VA ECMO and the potential impact on mortality. Additionally, we sought to determine if ipsilateral venous and arterial cannulas increased the risk of vascular complications. Patients who were peripherally cannulated via the femoral vessels on VA ECMO through January 2011 through December of 2022 were identified through an institutionally kept ECMO registry, and variables were obtained via manual chart review. Our primary outcomes were lower extremity vascular complications and in-hospital mortality. And we used multivariate stepwise logistic regression models to identify risk factors for both vascular complications as well as in-hospital mortality. We had a total of 605 patients on VA ECMO. The majority were male, white. The mean age was 56.3 years. And we had a high rate of hypertension and coronary artery disease. And notably, 130 patients, or 24% of our cohort, had identified peripheral arterial disease. 80% of patients were cannulated in our facility, with the remaining 20% being transferred from an outside facility. Over 90% of patients had same-sided arterial and venous cannulas, and the sizes ranged from 15 to 30 French for arterial cannulas and 17 to 33 French for venous cannulas. 83% of patients had distal perfusion catheters in place, and the mean duration of VA ECMO was 5.5 days, with 43% of patients surviving to decannulation. Ipsilateral vascular complications occurred in 72 patients, or 12% of our cohort, and the most common vascular complication was acute limb ischemia in 53 patients. Vascular surgery interventions occurred in 30 out of those 72 patients with vascular complications, or 42%. These included thromboembolectomy, fasciotomy, amputation, or surgical control of hemorrhage at the cannula site. In-hospital mortality for our entire VA ECMO cohort was 63.8%, and we did not show a difference in in-hospital mortality between patients with and without vascular complications. And this was 61% versus 64% respectively. On multivariate regression analysis, we identified increasing age and BMI to be risk factors for in-hospital mortality, but most importantly, we did not identify vascular complications to be a predictor of in-hospital mortality. Distal perfusion catheters did not protect against the development of acute limb ischemia in our cohort. It was present in 79% with acute limb ischemia versus 84% without. We found no association between the development of acute limb ischemia and same-sided arterial and venous cannulas in the cohort. On multivariate regression analyses, we identified predictors for vascular complications to include smoking history, peripheral arterial disease, female sex, and increasing arterial cannula size. So in summary, we do confirm the high mortality rate that is associated with VA ECMO. Vascular complications occurred in 12% of our patients. However, they did not pose an increased risk of overall in-hospital mortality. Same-sided venous and arterial cannulas also did not predict acute limb ischemia. The risk factors we identified for vascular complications on VA ECMO included smoking history, PAD, female sex, and increasing arterial cannula size. And the risk factors for in-hospital mortality included increasing age and BMI. Limitations to our study include all the limitations inherent to the retrospective design, as well as sampling from our single institution. We were also unable to assess the impact of inotropic support, specifically on the development of acute limb ischemia or compartment syndrome, although the majority of patients were requiring this support. Additionally, the diagnosis of peripheral arterial disease may not have been completely reported if it was not in the medical chart. So in conclusion, this represents one of the largest reported series of more than 600 patients. Vascular complications do not appear to increase mortality as previously reported. Same-sided VA ECMO cannulas and distal perfusion catheters did not predict vascular complications or prevent against them. And finally, understanding these risk factors for vascular complications while on VA ECMO may improve monitoring and diagnosis and allow for earlier intervention in this patient cohort. Thank you to Dr. Reed and my mentors, and I'll take any questions.
Nolan Sherlopan, Mayo Clinic. You may not know this offhand. Was there any difference in your data set in terms of percutaneous versus open cannulation? I know that in the cardiac surgery world is pretty hotly debated and contended between institutional preferences.
I can't give you the specific numbers, but I will say that 80% were cannulated in our institution, and the majority of those patients were cannulated in the cath lab with interventional cardiology. I don't know the exact percentage breakdown, though.
Dawn Coleman, University of Michigan. I really enjoyed your experience, and I think that the last comment was really an important one. To follow up on that a little bit, I believe that institutional patterns for cannulation and decannulation are highly variable. And not only that, but within institutions, you've got multiple specialties often now engaging this technology. So I'm just curious if you can speak to that at your institution, what that looks like, how often vascular surgery is engaged with these patients, whether or not it's elective or not. Vascular surgeons do play a large role in supporting these programs. It's part of our values, so I think it's an important concept. Thanks.
Absolutely. Thank you for your question. At our institution, vascular surgery is primarily involved after the patient has already been on ECMO. Usually it's the consult for acute limb ischemia. Typically, the cardiac surgeons do the decannulations unless there's some kind of complex thing they find in the OR, or if they need help decannulating. But typically that's who does that. And then to cannulate, it's both the cardiac surgeons and the interventional cardiologists.
Hi, thank you very much, Fahad Shuja, Mayo Clinic. I have a question about your finding that placement of a distal perfusion catheter did not prevent acute ischemia. Why do you think that was, and has this translated into the practice of ECMO cannulation where you're no longer trying to place those catheters? Thank you.
That's a great question, and something that is reported variably throughout the current literature. There are a few meta-analyses that do show that they are protective. In our cohort, the majority of patients had distal perfusion catheters. It's hard to say why the patients who did not have distal perfusion catheters did not get those. If it was just they didn't place it at the time, if they had difficulties. I know in one of the previous presentations we talked about the tibial, and we don't do that at our institution. If they can't get the SFA, they just don't do that. So I don't know the exact reason why we didn't see that in our cohort. It'd be something interesting to kind of compare down the line, but I was surprised by that result as well.
One more question.
Thank you. Ari from UC. That was a wonderful presentation. I have a comment and a two-part question. Very easy, just yes and no. The question first is for the perfusion catheters. have you seen if they were placed right at the time when ECMO, the whole cannulation was done, or were they placed after as a thought? And the other question was, did you look at wound complications as well, or was it just vascular complications pertaining to ischemia? And the comment is, well, collaboration, I guess, in the future. Well, thank you very much.
Yes, thank you for your comments. So we did not look at wound complications after your presentation. I was like, we need to look at that with our cohort right now. In terms of the distal perfusion catheters, the majority were placed at the time of the ECMO initiation. There may have been a handful of patients that were transferred into our facility without them and had to get their cannulas repositioned and then had one placed. But generally speaking, we did not have any delayed DPCs.
Thank you.
Thank you.